So, Dr. J.C. Sharma again, and we in continuation with the rapid review cardiology, we take a look into the history and physical examination. Mere history should reach you to the diagnosis, that what he has presented with. There are only a few symptoms which are pertaining to cardiology, which are pertaining to heart disease. Pain chest is the first thing. Most of the patients, they present with the pain chest site. Where is the pain located? Is it central? Is it in the side? How was the onset? What was the onset? Whether it was so sudden, whether it took some time, whether it was related with the exercise, and ask the patient to describe himself. What type of pain chest? Crushing, heavy, instantly worst. We discussed earlier also, aortic dissection, knife-like, tearing, a important type of pain. Radiation, where? Arm, left arm, both the arms, neck, in the back, maybe aortic dissection, maybe up to the epigastrium. And what are the associations? Whether the shortness of breath, the breathing difficulty was accompanied by the chest pain, or there was nausea or sweating. Sweating with pain chest may be indicative of myocardial infarction. What were the exacerbating factors and what were the relieving factors? Did he take rest and it got relieved? Or if it didn't get relieved with rest also, whether got relief from the nitroglycerin or no relief. So these are the important findings, the important history to be elicited. Whether the pain increases with the respiration in any position, any movement, which may suggest it may be a musculoskeletal. Severity of the chest pain. What is the severity? You tell the patient to compare with the 10, which is the highest severity, 6, 7, 8. What is the intensity of the pain? Was the patient known angina or a chest pain? Whether it has become better or it has become worse? How frequent? Is it appearing with the decreasing exercise? Or there is a heartburn like of thing? Whether it is increasing with the drinking? Whether it is increasing with the eating? These are esophageal pains, as you know. Worse when lying down, or it is associated with dysphagia, deglutition. This is a very short list of types of chest pain and the diseases. We just go one by one. What is there in stable angina? What happens? The cardiac pain, myocardial ischemic pain, pressure, tightness, squeezing, heaviness, burning. But as I told you, it may differ from patient to patient and in their feeling also. We get the patient who say that I have got a feeling that something has stuck in the throat since yesterday. So it's not a normal thing and you should suspect a cardiac event only. So if it is precipitated by the exertion, cold or stress, it's angina. If the pain doesn't go by the GTN or rest and continues more than 20-30 minutes, maybe myocardial infarction, ask for the ambulance, reach to the hospital. Location, very important. Retrosternal, radiations. We have talked about the radiation many a times, and it still holds true that each and every patient, one should meticulously ask where the pain goes. And as we discussed earlier also, the pain may range from jaw to epigastrium. These can all be the pain of myocardial infarction. Pericarditis, an important differential diagnosis of acute chest pain. So it's a pleuritic type of pain. It may be retrosternal, may be precordial, may be in the side. It may radiate into the shoulder also. But when the patient sits and leans forward, it gets a little relieved as far as the pain is concerned. So these important two types of pain, aortic syndromes, including the aortic dissection, tearing type, ripping, knife-like pain, radiating in the back, but in the ascending aorta dissection, it can only be retrosternal also. So don't forget that this may be a aortic dissection, and then compare with the radial pulse in both the arms if there is some delay or anything. If you see, then their associated hypertension may be there, underlying connective tissue disorder, or a thing like Marfan syndrome, which can precipitate the aortic syndromes. Pulmonary embolism, very sudden in onset, instantaneous again, just like aortic syndromes. It is pleuritic. It's such a heaviness and associated with breathing difficulty. Dyspnea, tachypnea, tachycardia as well as hypotension, hypoxemia, less than 85%, maybe less than that. Pulmonary hypertension is a dull type of pain, a constant pressure, maybe substernal, and there can be a signs of increased venous returns. Gastrointestinal pain may be confused and mimic the myocardial infarction pain, myocardial ischemia pain, esophageal reflux, spasm, peptic ulceration, gallbladder disease. Gallbladder disease may present as epigastric pain, right hypochondriac pain. So these pains should be kept in mind. But first and foremost important thing is whether the chest pain carries a risk of myocardial infarction, aortic dissection, esophageal rupture, or say pulmonary embolism. These are the things which are constantly kept in mind whenever the patient presents with the chest pain. In the same way, costochondritis, teat syndrome like thing. You pressure there, it is all inflamed. You press it, there is a tenderness. So only what you have to do is, you have to give NSAIDs, you have to inject locally. Or it may be a cervical disc which may radiate in the arms and shoulders also. This should be differentiated from the myocardial ischemia pains. Trauma may lead to pain, has to be elicited if there was a trauma. Herpes zoster, it comes as a surprise. The distribution may be same as that of cardiac, and the vesicles don't appear by second or third day. So it's again very difficult to make out, and for first 2 days you may think that it may be a cardiac pain. Emotional and psychiatric conditions and the anxiety, this may all lead to any kind of pain, any panicky attack, and a sense of doom may be there with a emotional and psychiatric pain. Palpitation. What kind of palpitation? The best thing is the patient describes himself. What kind of palpitation? Ask him to just tap the table, the type of feeling he has or he had in the earlier. When and how did it start? Was it related with something, some activity or anything? What is the duration? Was it sudden or gradual? Like atrial tachycardias, maybe gradual, maybe sudden, paroxysmal atrial tachycardias, supraventricular tachycardias, whether associated with blackout, chest pain, or whether it is food related, caffeine, alcohol, paroxysmal atrial fibrillation as a Saturday holiday syndrome is a very common phenomenon. Whether it is regularly fast or whether it is irregularly fast, I should say. We will come down to that also. If it is totally irregular, it is a AF, it is a atrial flutter with a variable block. So these are the conditions where the patient describes the pain as irregular. Dropped up or missed beats, whether more on incumbency, regular pounding due to anxiety, very common. Slow palpitations, a thump on the heart with the beta blockers. If the heart contracts only 40 or 50 times, he may feel a heavy heartbeat. Reassurance is vital, very important, and send for the thyroid test. If it is irregular or something, 24 hours of Holter monitoring, you advise then and there in the emergency room. Dyspnea, breathing difficulty, sense of breathing, and a feeling of heaviness is also a cardinal feature of myocardial disease, heart disease. So how it comes and where did it start? How much exertion, say walking a staircase or just lying down also breathing difficulty, whether he had to get up in the night and gasp for the breath, that is also important. PND, which we call paroxysmal nocturnal dyspnea. So intensity of dyspnea and its category is also very important. Syncope, did he lose the consciousness? Whether it was of short duration? Cardiac is not a long duration. The cardiac is short duration and CNS is long duration. Any warning like a pre-syncope, warning of palpitation, warning of some dyspnea, then it may be related with the cardiac. If there was premonition like an aura, then it is neurological. What was the patient doing at that time? Whether sudden or gradual. Sudden syncope and sudden recovery is a feature of heart disease and arrhythmias rather than the neurological, where the patient gets up with confusion and a tongue biting, seizure and all this. So seizures and this kind of dizziness or syncope can be differentiated. Witness account is something very important. If somebody saw him suffered a loss of consciousness, the LOC was witnessed by someone. Ask, he may be a family member, he may be a office colleague, or he may be a onlooker, and he lost the consciousness. So these features can differentiate the reason for loss of consciousness. Vertigo, feeling of rotation of the surrounding. Not very common with the cardiac. Imbalance, maybe more of the cerebellar sign or from the central nervous system, like posterior column involvement. These are the important regions, but sometimes a temporary imbalance may happen. Lightheadedness, carotid sinus hypersensitivity, which can be reproduced also. This is also important. Whether there was anemia, whether there was a postural hypotension. We will talk about the postural hypotension a little later on also. Hypoglycemia, don't forget, it's very important for loss of consciousness or abnormal behavior. Claudication, where is the claudication? I tell you, the most common mimic and the problem in diagnosis is a buttock pain. It can be a gluteal claudication, which a person may feel it's a hip joint pain. So this can be mistaken. We know of claudication patient presenting to orthopedic surgeons. So just ask them. A social history of smoking, alcohol, what are his hobbies, family history. If there was a first degree relative who suffered from the heart disease below the age of 60 years, it's a little significant. If there is a drug history, whether the patient was already on the anticoagulants, we come to know what it was like. If there was a angioplasty, bypass surgery, you keep on asking the patient. Somehow a few patients may hide these important histories also. May not be intentional, but they think that the doctor should make out what I am suffering from. So what are the risk factors for heart diseases? These are 5-6 reasons which everybody should keep in mind. Family history, not to be forgotten. It runs in families, I am sure. Diabetes mellitus. Now India is becoming a diabetic capital in the world also. Smoking, without any doubt, that it increases the chances of heart disease. Hypertension is the risk factor, and hyperlipidemias are the risk factors. These are the risk factors for ischemic heart disease and should be elicited meticulously. Examination. How the patient appears. Does he appear very unwell? We have to see this very carefully. Does he keep the GTN spray around himself, or he is on oxygen already? Whether he is cyanosed, whether he is flushed, or there is a shortness of breath. If there are any scars on the chest, like a CABG scar or some device scar like a defibrillator or pacemaker, hence important things. You keep on reading about them, whether there are splinter hemorrhages, osseous nodes on the finger pulp, Janeway lesions, macular, which are not tender at all. They are also thought to be embolic, and nail fall infarcts are also very common. But peripheral signs of infective endocarditis, all in all, are not that very common. Keep this, including the clubbing, keep this in the mind. That don't believe in these much. Roth spots, if you find these things, have a look into the retina also. Whether the patient is cyanosed, whether his fingers show that he is a smoker. Nail bed capillary pulsation things can be elicited, can be seen in polydactyly, and Marfan's, as I told you, is associated with aortic dissections. Pulses. These are the common pulses which we should look for. Carotids, brachial, radial, femoral and dorsalis pedis. Rate below 60, above 100, we know these are sinus bradycardias and tachycardias. Radial delay is also very important, and radiofemoral delay is also very important. Radial delay may be because of coarctation and aortic aneurysms or a vasculitis. Radiofemoral delay, as you know very well, is a coarctation of aorta. Anybody, any young person who suffers from hypertension Once in lifetime, a doctor should always compare the brachial femoral arteries and if there is any delay or weakness. So where is the brachial artery? It is just medial to the biceps insertion. Collapsing pulse. You have the hand on the pulse and you realize that yes, it looks like a collapsing pulse. Once you see it, you will never forget. Face may show many things other than the big syndromes. You look for the gentle asthmas. Dyslipidemia shows. There is a malar flush in mitral stenosis because of the low cardiac output, but only in our country. If there is a goiter, exophthalmos, the patient may suffer from atrial fibrillation, sinus tachycardia. Downs, Noonans and Marfans, these are very clear and should be carefully seen. So have a look into the patient. A blood pressure, systolic and diastolic, should be seen. Office readings and first reading may be a little higher. So hypertension stage 1 is a 140/90 and up to 160 it is a stage 1. Anything more than 160 and 100 are stage 2 hypertension and should be looked for it. If the blood pressure is more than say 150/90, another arm pressure should always be seen. Arm and leg pressure should always be compared once at least. It may be a surprise for everyone that the patient suffered from coarctation and nobody saw this first. Postural hypotensions are very common. Soon the patient rises in the night for toilet or anything. There is a drop of blood pressure and he feels dizzy or he may have a hypotension. So what is the postural hypotension? 20 and 10, systolic and diastolic. If he rises, then this is the fall usually seen. What are the reasons? Elderly, there may be many reasons, but including the autonomic neuropathies in diabetic patients and multi-system involvements. There are some examples of some different postural hypotensions. A marathon run, and you know that the Olympics just took place. So it's a 2-3 hours of running may lead to a decreased peripheral resistance and a hypotension for some 2-3 hours. So this should be kept in mind. Nitrates, diuretics and antihypertensives, they may all lead to postural hypotension. Antipsychotic medication is an important example. Pulses, fast, slow, rhythm, irregularly irregular or completely irregular. Irregularly irregular may be a ventricular bigeminy, important thing. Second degree heart block. Bounding pulses. Pulses may be bounding in CO2 retention, COPDs, in liver failures and in sepsis. Small volume pulses, aortic stenosis. We will come to the pulses later on. Into the shock, pericardial effusion pulses may be a small volume pulses. Collapsing pulse, mesmerizing finding in AR. Everybody looks for it. Easy to look and easy to see also. Aortic regurgitation is the reason for bounding pulse, for collapsing pulses. Water hammer was the toy which was much available. Now possibly it is not available these days also. So arteriovenous malformations, patent ductus arteriosus. These are the reasons for water hammer pulse. If there is a slow rising pulse, parvus et tardus, you know it is aortic stenosis, slow rising pulse. Alternans, LVF. Left ventricular failure, dysfunction, aortic stenosis may lead to every alternate pulse as large volume and less volume like strong and weak beats, jerky in hypertrophic cardiomyopathy and obstructive element, paradoxus, again an important thing. Systolic, it decreases the pulse, I mean the volume, with inspiration. More than 10 millimeter if you see the blood pressure, it is paradoxus. Occurs in constriction, cardiac tamponade, and it occurs in the COPD as we were discussing. These are important type of pulses which should be kept in mind. I have shown these caricatures and very diagrammatic diagrams, I should say, that what happens in aortic stenosis. You can see a parvus et tardus anacrotic type of pulse. Normal, this C wave is usually not palpable, otherwise slow rising pulse is aortic stenosis. Besparian pulse is a combined aortic lesions. Collapsing pulse, you know it very well by now that the aortic regurgitation. If you don't see the pulse, don't forget, you may see either a occluded artery or the patient may be in the shock also. Should be kept in mind in the emergency room. Jugular venous pulse. So we continue with the JVP, and the first question is whether the pulse is venous. Venous pulses are usually impalpable and they are obliterated by the finger pressure. This is the important point. It is transiently raised by the hepatojugular reflex. This is also an important point, and it changes with the respiration as well as by the position. He lies down, they are filled up. They get up, you don't see the upper end. In the same way, with every arterial pulse, there are two venous pulses, A and B. JVP is normal in waveform but are raised. If there is a fluid overload, the patient is lying in the bed and you see the fluid overload, JVP may be raised. This may be the first sign, or in right heart failure. The fixed rate JVP is a obstructive superior vena cava syndrome, absent pulsation, but it is raised, filled up, whole face is filled up by the vein. Large A waves may be there in the pulmonary stenosis as well as pulmonary hypertension. These are important reasons for the JVP raised. Cannon waves, if right atrium contracts against a closed tricuspid valve. What are the reasons? Complete heart block, important. Single chamber ventricular pacing, so it is not synchronized pacing, may lead to a atrial contraction against a closed tricuspid valve. Ventricular arrhythmias, if the pulse arises from the ventricle, it may lead to A waves. If there are no A waves at all, it can be atrial fibrillation. A waves is not seen, that is the first thing. Large V waves in tricuspid regurgitation. Rather, there are CV waves. These are known as CV waves. With right ventricular contraction, just like a artery, the pressure rises in the JVP, and even a ear lobule may move with the tricuspid regurgitation. Constrictive pericarditis, very important thing, Kussmaul, increases with the inspiration. Rather than decreasing, it increases. So this is important sign, and you see the filled up jugular venous waves. Deep X and Y descents are there with the constrictive pericarditis, but with the tamponade there is only X descent, not the Y descent. If JVP is absent, that is not filled up, it may be a dehydration, hemorrhage, you see them very easily. JVP must be the first sign when you can find out that the patient is dehydrated. These are very simple to show you that the A wave is usually because of the atrial systole, that's why it is absent in atrial fibrillation. C wave not seen on the descent of the X descent, not seen. Fall of pressure during ventricular systole, this is the ventricular systole between C and V, and Y descent is the opening of the tricuspid valve in the early diastole. This I have shown for the JVP because of the fact that we should look for internal jugular vein only, not the external jugular vein. External jugular veins in fact are small and they may contain valves. So they are not the right manometer for the right atrial pressure. This is the anatomy which should be kept in mind as far as the jugular venous pressure is concerned. Go back. You can see the clavicle, and this is the manubrium. Above this, the raised GVP you look for. Hard sounds. While looking for hard sounds, always see a carotid artery. At the upstroke, this is S1, hard sound, first hard sound, which is produced by, first hard sound is produced by mitral and tricuspid closures, M1, T1. Splitting in the inspiration may be there, but may not be very important also, but in inspiration, the first hard sound may split a little rather. This is a very useful, I should say, a diagram, because this is comparing between ECG, hard sounds, aortic pressure waveform and left atrial pressure, as well as the hard sounds. So it is very important to keep this every time in your mind that when should this hard sound come. But we will usually describe about everything. First hard sound, loud, mitral stenosis. That is the first hard, that is the narrowed orifice which causes the loud M1, because of the fact that during diastole the mitral valve remains open till late in the diastole. Then it comes the systole, it closes with a snap, and that is known as the mitral stenosis, first hard sound, loud. Even after it being a atrial fibrillation, it is always present. So look for the first hard sound and you will see that there is a mitral regurgitation. Limits the ventricular filling, as I described you, this is important. So in short PR interval also, the valve remains open till late in the diastole. So when the S1 comes, there is always a loud sound. In the same way, intensity may be variable because of the AV block, because of the fibrillation, and because of the ventricular tachycardias when atria and ventricles are contracting independently. This is for hard sounds, and very good to know these. In fact, aortic normal S1 and S2 contains what? What are the two sounds which make S2, A2 and P2? Aortic closure, pulmonary closure make the second hard sound. We will come to second hard sound, which is much more important in fact, other than the mitral stenosis snapping. In ASD, it is fixed and split. Why it remains fixed? Because of the fact that during inspiration and expiration both, the venous filling of superior of right atrium remains the same because of the ASD. When during inspiration, superior vena cava and inferior vena cava fill this, and during expiration, the left atrium fills it. So it remains fixed and split and loud as well. So it is an important finding as far as the ASD is concerned. Where do you look for split second sound? Pulmonary area, because there the pulmonary sound is heard very nicely. If it is loud, better way you can appreciate, and you look for fixed sound also in the pulmonary area, that is in the left second intercostal space. So in expiratory splitting, now just think about the P2 delay, and you can see that the RBB will produce this, the pulmonary stenosis will produce this. These are the reasons for the delay in the pulmonary sound that will be increasing the split. Reverse splitting when A2 becomes late. Aortic sound is late. This is reverse splitting. Don't be bogged down by these words, reverse splitting. Don't worry, aortic is coming late. So simple to understand. When will the aortic sound will come late? When there is a left bundle branch block, when there is aortic stenosis. These are the reasons for delayed A2 that will cause a reverse splitting. A2 should come first, but here in reverse splitting A2 is coming later than P2 sound. There may be a close fixed splitting during pulmonary hypertension also, because the pressure remains the same and the venous filling does not make much difference as far as the right atrial filling is concerned. What is second heart sound? We were talking about it, aortic and pulmonary valves. Most important abnormality is softening in aortic stenosis, easy. In tachycardia also, A2 may be loud, but we don't look for these because they are not very clinically important. P2 loud in pulmonary hypertension because of the increased intensity. P2 soft in pulmonary stenosis. Stenosed valve don't make much noise also. If there is a splitting, as I described you, second heart sound splits because of the inspiratory, expiratory, same inflow into the right atrium. Wide splitting? Maybe because of the RBB, because the pulmonary sound is coming late. Deep inspiration may produce it. Pulmonary stenosis, we talked about them, and VSD may also lead it because of the high circulation on the right side. Wide fixed splitting, we were talking about it, you know that it is ASD. Single sounds are there if the pulmonary sound is absent. I should say which are the reasons for Fallot's. It may be a atretic valve. Eisenmenger also doesn't cause pulmonary closure. So large VSDs and hypertension, these produce hypertension and these produce the single sound. Reverse splitting, we have already talked about them, that the left bundle branch block, aortic stenosis, these are the main reasons. Now come to the third heart sound, important sound. Up to 30 years of age, this can be a normal finding. Above 30 years of age, you start looking for the pathologies. So why it is causes LV dysfunction? Third heart sound always tells that there is a LV dysfunction. So in dilated left ventricle, a third heart sound will be loud. In the same way, post-MI period or decompensated dilated cardiomyopathy may also lead to a third heart sound. So third heart sound denotes heart failure, left ventricular systolic dysfunction. There is another sound which is heard in diastole in constrictive pericarditis and restrictive. This is known as pericardial knock. This may also be like a third heart sound. So this should be kept in mind. There is a knocking, halting sound which is produced because of the constrictive pericarditis. Fourth heart sound, always pathological. This sound is because of the atrial contraction against a ventricle which is made stiff by any cause, say aortic stenosis, Hypertensive heart disease, these are the regions which can produce a left ventricular stiffening against which the atria contracts, and this leads to fourth heart sound. Always pathological, we talked about it. What is the gallop rhythm? Important rhythm. Third and fourth heart sound both are there, and there is a tachycardia. This will lead to a galloping sound. You must have heard the horses galloping, the hooves galloping sound. That sound is produced if the S3 and S4 both are there, as well as there is a tachycardia. In suppose there is a situation like pulmonary embolism, summation gallop may be heard in this situation. Ejection systolic click, important click. We are talking about the clicks. Bicuspid aortic valve is the most common region. When the aortic valve opens, there is a click. Bicuspid BAV is an important region. Mid systolic click, we will talk about it much later on also. Mid systolic click is MVP, mitral valve prolapse. And the click murmur may vary. If you auscultate dynamically, then you may hear it moving between S1 and S2, between S2 and S1, with the positions, valsalvas, sweating, and many maneuvers. We will talk a little later on. So mid diastolic murmur of mitral stenosis is assured after the opening snap. In the diastole, sooner the opening snap comes, tighter is the mitral stenosis, and longer is the murmur, tighter is the mitral stenosis. So these are the signs which you see carefully when it comes to physical examination. Heart sounds important to look for if the patient has undergone a valve replacement earlier, because they may show you whether the valve functioning is okay or not okay. So the mechanical valves, mechanical prosthetics, they produce the sounds, not the biological valves. Bio valves don't produce much of the sounds. Rumbling sounds will be there, although this valve is not available now, but star valves, this is a ball and cage valve, has lasted for around 20 to 30 years, and you may still find the patients with star valves, particularly in the aortic location. If there is a single click, it may be a single tilting disc. Shelley valve and Medtronic Hall, these are the valves which are single tilting disc. Medtronic Hall is also less available these days. Bileaflet valve, they are quieter valves, St. Jude's, and these are valves which don't produce much of the heart sound as far as a star valve is concerned. Prosthetic mitral clicks take the timings of S1 because they are at the mitral position. Aortic valve clicks, they time at the S2 because they are in the aortic position. So simple to understand. These are the areas, you know them very nicely, but even then I want to tell you that these murmurs and sounds you hear in these areas more. So we go with the apex. Mitral murmurs are very nicely heard on the apex. They radiate MR murmur, radiate to either axilla or may in the base of the heart. VSD murmur on the right side, it is vibratory murmur, very clearly heard, and even if you don't put the stethoscope, you may really find in pulmonary areas, left of the sternum, aortic area is the right of the sternum, where the aortic murmur, stenotic murmur goes into the carotids. So very nicely depicted in this in these areas over the precordium and nearby it, which will show you which murmur is heard where. So the bell of the stetophore low pitched. Keep it in mind. There are two things in a stethoscope. With the tubings, there may be a bell and there may be a diaphragm. So bell is better. But if you press it hard, it becomes a diaphragmatic also. So if the sounds like MS, bell of the stethoscope, keep the patient left lateral. You may really hear it nicely. So diaphragm filters out the low pitches like a murmur of AR, and very difficult to find out also. I will tell you where to look for. What is the character? Rasping type or soft type? Loudness. Where is the loudness? Where is the loudest? What are the radiations? We have already talked. Accentuating maneuvers also we will talk about it. Valsalvas, squattings, post-ectopics. These are the maneuvers which changes the murmur. Respiration, left lateral positions, character, ejection systolic, very common murmur. First goes very high, crescendo and decrescendo. Aortic stenosis murmur, ejection type of murmur, aortic stenosis in the pulmonary area, pulmonary stenosis. This ejection murmur may be really an innocent murmur in children and high output states like pregnancy. These are to be important. Like in pregnancy, many of the sounds and murmurs may be physiological, and don't mistake them as a pathological murmurs. If in doubt, see the echocardiography. So what are the organic causes? We have already talked. Aortic stenosis also. Aortic sclerosis, thickened calcified valve but without any obstruction. Pulmonary stenosis and HOCM. We will talk more about the HOCM. Pansystolic murmur, uniform in intensity from S1 to S2, merges into the S2, extends beyond the S2 also in fact, and this is all because of the mitral regurgitation, aortic regurgitation. VSD murmur, important to rule out. Where it goes, I have already told you, on the right side. It on the both the sides of the lower sternum, you can find out the VSD murmur. Mitral valve prolapse, it will produce the click and murmur, in which changes with the positions. This is an important diagram, I should say. The click and murmur becomes near the S1, near the first heart sound, if there is more impedance to the output, that is after load. If it increases the after load, then the murmur is more. In the same way, if the contractility increases, murmur is more. If the volume decreases, murmur is more. These are the maneuvers. A good diagram to show you that how the HOCM and mitral valve prolapse murmurs may differ with the maneuvering and positions of the heart. S4 murmur, I should say, a pre-systolic murmur in A diagram, important just before the S1 because of the atrial contraction, don't forget. Pansystolic murmur, you can find out, it overspills the S2 also, VSD, mitral regurgitation. Mid-systolic murmur, mid-systolic click and murmur, click here it starts and there is a murmur. This and this. In the same way, if there is a early diastolic murmur, you can see just after the aortic second sound. Rather, you look for the absence of noise there. There is something in the early diastole. It is very important to see. In the same way, continuous murmur. We will talk about these murmurs also later on. That the murmur lasts systole, diastole both, because there is a pressure gradient throughout the systole and diastole. They are hardly cardiac, but these are important murmurs. We will talk in later on. These are the maneuvers which produce and changes the murmur of mitral valve prolapse like this, as I have already talked. Early diastolic murmur is what? Aortic regurgitation. So absence of silence is the thing which I wanted to tell you, because you may not appreciate the murmur. It's important to see for the AR murmur. In the same way, aortic pulmonary regurgitation murmur is known as a Gram-Steele murmur and may happen after a pulmonary hypertension secondary to mitral stenosis. So these are the reasons for early diastolic murmurs. Mid-diastolic MDM, which is the most common murmur and most often asked to look for, is a low-pitched murmur. Much more if the patient is left lateral and seen by the bell of the stethoscope, as I told you last time. If the patient is in sinus rhythm, there may be a pre-systolic accentuation of this murmur. Rheumatic murmur, rheumatic fever this murmur may cause a Kerry-Coombs murmur. Because of the thickening of the leaflets and the blood flows during the diastole, this may lead to a Kerry-Coombs murmur. In the same way, Austin Flint murmur due to fluttering of the anterior mitral cusp in AR. Important finding as far as the AR is concerned. So in AR there may be early diastolic murmur as well as mid diastolic murmur. These murmurs are to be looked very carefully and easily appreciated also, even for a beginner. Continuous murmurs, there is a continuous gradient between the systole and diastolic. Where? PDA. In this, there is a constant hum with a diastolic component increasing just before the S2 like a mechanical murmur. Once you hear this, you will never forget. If there is a reversal of the shunt, there may be a differential cyanosis. We will talk later on. Ruptured sinus of Valsalva aneurysm on the right side. PDA is on the left side of the sternum, but the ruptured sinus is on the right side. There is a communication between the aorta and the right heart chamber. Maybe a atrium, maybe ventricular. This is also a continuous murmur. Coronary arteriovenous fistula is also a murmur you will hear throughout the systole and diastole. AV fistula at the site of hemodialysis, very nice to auscultate. Sometimes you people look for this. You will never forget a continuous murmur if you look a fistula. Aortic coarctation, what happens in this? Continuous murmur it produces, and it is near the ribs. Look for them because of the collaterals. Enhanced flow into the enlarged collaterals will produce a intercostal continuous murmur. Cervical groove is the thing which you should look for, because there are both the components, systolic as well as diastolic, and it shows that there is a high grade carotid stenosis. There is a gradient throughout the cardiac cycle of systole and diastole. In the same way, there is something which is very innocent thing and should not be mistaken for PDA and other things. It's a venous hum. It happens in healthy children, young adults, pregnancy, and can be obliterated in the if you press at the supraclavicular region. In the same way, right internal jugular vein, if you just press it also, then the venous hum can be obliterated and it's a benign condition. Pregnancy shuffle is known as mammary shuffle. You press with the diaphragm and it disappears. appears in the third trimester over the breast, or maybe in the early postpartum region also. Firm pressure, as I told, can eliminate the murmur. Intensity of the murmur. People always talk much about it, and you should know what is the intensity of the murmur. First of all, a little of the classification. 1 to 6 is systolic murmur, and diastolic murmurs are really softer. So you find only 1 to 4 only. So systolic murmurs are grading should be done from 6 by 1, 6 by 2, like this. So very soft murmur, 1 by 6 is a very soft murmur, and you have to keep your stethoscope for some more time. Then only you will appreciate. 2 into 6 is the murmur, 2 by 6, which is soft, but soon you put the stethoscope, you realize there is a murmur. In the same way, 3 by 6 is clearly audible, but thrill is only with the 4 murmur. 4 by 6 is a thrill. 3 by 6 is a clearly audible murmur. 5 by 6 is quite a big sound, and you partially touch the stethoscope, you will find the murmur. Even with a distance also, you can hear the 6 by 6 murmur. So these are the intensities of the murmur. Should be kept in mind that how intense is the murmur. Area where loudest, we have talked about it earlier also, we repeat it. Mitral murmurs at the apex, aortic right second interspace, pulmonary second left interspace, tricuspid lower left sternal. Radiation, ejection systolic carotids, we have talked. Diastolic murmur, systolic axilla or of the base, even at the occiput in cases of MR. So MR murmur, you will look into the axilla, systolic murmur I mean, and the aortic stenosis murmur, you will look into the carotids, and VSD murmur you will see on the right side of the sternum. Accentuating maneuvers, as I told you, after say some exercise, you listen the MS murmur much more. So bring the heart closer to the stethoscope, accentuates the murmur. Where it happens? Left lateral in mitral stenosis. If he leans forward in AR murmur, heart comes near to the stethoscope. Inspiration murmur, right-sided murmur are more in inspiration. Left-sided murmurs are more in expiration. Valsalva. What is Valsalva? If somebody asks you to describe, forced expiration against a closed glottis. That is the crux of the thing. That's how the Valsalva is produced. I have seen one very small girl, say 10 years old, who could perform the Valsalva for her treatment of SVT, supraventricular tachycardia. In some 10-20 seconds, the tachycardia will disappear. She demonstrated it twice and thrice in front of me. Such a nice demonstration I will never forget in my life, and you should also not forget that this is forced expiration against a closed glottis. So, decreased systemic venous return happens because of the Valsalva. So, both the murmurs are increased because of the decreased venous return, obstructive cardiomyopathy and mitral valve prolapse also. But on the contrary, there is softening of the MR murmur and stenotic murmur because of the decreased venous return. Squatting increases the venous return, so it softens the hypertrophic cardiomyopathy murmur and mitral valve prolapse murmur. Just the opposite thing, but in the same way, it accentuates the aortic stenosis murmur because of the more cardiac output and AS murmur. Exercise accentuates the mitral stenotic murmur. Sometimes what you have to do is you do some hand grip exercise or ask the patient to walk and listen. The mitral stenosis murmur may be very clear to you. Pericardial friction rub, pericarditis. Never forget, it is a superficial scratching sound. Once you listen into both the phases of systole and diastole, you will never forget a pericardial rub. What happens in prosthetic valve murmur? They are abnormal usually, I should say. If there is a murmur in a prosthetic valve, sounds are alright. They show it's a good mechanical prosthesis. But when it comes to murmur, these may be abnormal. So how the prosthetic valves are created? They are created from the synthetic material as a mechanical prosthesis or a bioprosthesis. Anticipated longevity, say in the age of 65 years, if around 10 or 15 years, we go for the biological valves. The choice of the valves go by the age or the situation, like anticoagulants. If a girl wants to extend her family, which everybody in our country want, then we will like to put a valve which does not require lifelong anticoagulation. Very important consideration and should never be forgotten, particularly in our country. In the same way, mechanical valves are of three types. Cased valve, now out of fashion and possibly out of production also. Tilting disc, Medtronic Hulk and George Shorey. By leaflet, there are two leaflets in this valve and less of the gradient. In the same way, tissue valves are of two types, porcine derived or a bovine pericardium derived. So this is the classification of the prosthetic valves, and one should know how the prosthetic valves are made, because you have to have a prosthetic aortic valves. We talk a little about it. All types of valve produce some outflow obstruction. So there may be ejection systolic murmur. Don't worry about that murmur. The intensity increases if these valves fail. Keep in mind. Ball and case valves and tissue valves, they close completely during diastole, and any diastolic murmur, even shortest, implies a valve failure. Must be kept in mind. It's very important. In the same way, prosthetic mitral valves, ball and case valve, may cause a low intensity murmur because of the interference into the ejected blood. So that should be ignored. In the same way, if they have got a diastolic murmur, it can be there. But any systolic murmur is abnormal in mitral position. This is an important point, should be kept in mind and should be looked after very carefully. So something interesting as far as the peripheral signs are concerned. These are asked in the examination, what is this sign? These are asked bedside also, and some very interesting signs are there with the aortic regurgitation, because these were elicited by these physicians first. So these go after their names. Head nodding is a D Muse with every pulse. Muller sign is a uvula movement systolic pulsation. Corrigan's is a carotid pulsation. In the same way, Quincke's is a capillary pulsation in the nail bed. Trough's is a pistol shot which should be heard on the femorals, and Dury's is to and fro diastolic murmur sound which can be heard by compressing the femoral artery with your stethoscope.